Hi, everybody. We're now back for our the panel discussion and the questions and answers. Thanks so much for listening in. And I know we've seen a lot of questions come through in the chat room. So let's go ahead and open up for discussion. I'm going to just take some of these questions and address some of our speakers today. So I'm going to start with Dr. Melinda Gooderham. We've got several questions about some of the topicals. And the first question was, can you tell us a little bit more about, you mentioned proactive treatment. Tell us a little more about that. Can the 2 days be consecutive? Can you chat a little bit about that, please?
For sure. Typically, when you are doing this proactive maintenance, so when there is active skin disease present, you would use the topical twice a day. And then once the skin appears normal, we know it's not really normal. Those immune cells are hiding out, waiting to be activated. You would put the topical on then twice a week. I believe some studies have been done with 3 times a week, but this would be spread out. So I would recommend, I usually tell my patients Monday, Thursday, but we can decide in another 2 days that's more convenient, but I would recommend spreading them out and not doing consecutive days if you're looking for proactive control.
Thank you. That's great. Question for Dr. Michael Cork. You mentioned briefly the increase in allergies in the BEEP study. Can you surmise what might be going on there?
Thank you, Amy. What we think's going on is that the emollients used are damaging the skin barrier in this particular population, and that's then allowing allergen penetration. And so this is now generating a whole area of work to investigate different formulations in this age group, looking at allergen penetration and bringing us back to this whole area of developing skin in a baby. Would anything damage the barrier and allow allergens to go through? So clearly there's a lot of work to do before anyone thinks of performing another new prevention trial.
Sounds good. Here's a question that I'll take. Will any of these systemic medications be disease modifying? Whether we're talking about for the atopic dermatitis or the potential risk of developing polymorbidities like asthma or allergies. And I think the answer is, well, we don't really know. We have certainly some experience with individuals who have been on the medication dupilumab and stop the medication and can have a short period or a long period before the eczema comes back sometimes with a vengeance. So we know that can happen, and for the most part, we are keeping people on that. Could we modify the course, particularly in those younger children, if we start it very early? And again, we don't know the answer, but as you've heard repeatedly and well know, the immune system is developing during these early years, and there might be some opportunity for modification. Dupilumab is just the first systemic therapy out of the gate that's more targeted. And I think it's going to be very important as we look at that to see what happens down the road. I think it'd be particularly interesting to look in the younger children at the risk of developing an atopic comorbidity like asthma, in particular food allergies, if they haven't occurred yet at the time of the atopic dermatitis, certainly allergic rhinitis, especially with agents that we know can affect and be therapeutic for many of these also Th2 driven disorders. We don't know that yet. They are potentially going to be hard trials to conduct. When we've tried to do that with topical agents, it's very hard to have a control group. And I don't think any of us are ready to just put a large population of young children who are just at risk on these agents to prevent their risk. I would also say that just because somebody has severe eczema does not mean that their asthma or allergic rhinitis is severe. So we also don't know not just who's going to develop it or not, but also what the ultimate severity is going to be when we're thinking about whether something will modify the risk factors for patients. But it's a very important question and one that we're all thinking about. I'm going to bounce the next question.
Amy, may I comment a bit about this?
Yes, and I was going to ask you another question in a minute, but go ahead.
Yeah, it's about the capability of disease modifier of these drugs.
Yeah.
And of course, I think that there's modifying, disease modifying is not, in my opinion, it's not linked to any drug. It's linked to the eczema control. I think we can actually modify the disease with the current drugs that we have. The problem is that we cannot use them properly in infants. But I think it's controlling eczema very early, what may lead to disease modifying. It's not I don't think it's drug driven. It is eczema free driven. This is my opinion, but of course.
Yeah, you know what? I will add to that, Antonio, to say that I very much agree. I know we all have an experience that's not really been tested, that's very difficult to test. And that is that we see so many of these young babies coming in with severe disease. We treat them appropriately with topical agents. And by the way, we're not worried about using a medium strength agent or even something more potent for limited periods of time. And if we're not aggressive, we cannot necessarily get there. So I guess another thing to just mention to everybody is that you can't be too timid about treating aggressively initially, because what many of us have found is that appropriate and safe treatment early on just with topicals not only seems to control the disease much better, but seems to then lead in so many of these terribly affected babies to a much milder or even barely recurring atopic dermatitis that is controlled with much milder topicals moving forward, or certainly never back to the state as when these children originally came in. So thank you, Antonio, for bringing that up.
Or if eventually some of these kids get completely cured.
Yes, that's right. And of course, this is a disease that self-limits anyways. So
Amy,
we know eventually that certain numbers will turn around. Michael.
Amy, can I pick up on that as well?
Yes.
I completely agree. This is very hard to predict if we're going to see disease modification, and the hardest absolutely is in the young babies. But now that we've been treating children for 5 years with dupilumab, we have seen some really quite remarkable things. You know, a 7-year-old, 100% body surface area, easy maximum, IgE 155,000. And after 4 years, he finally, 70 days in hospital for IV antibiotics in the year prior to dupilumab. And then after 4 years of dupilumab, he's been totally clear for at least a year. So clear for a year being really important. And then he comes off and it doesn't come back. And that, we don't know is disease modification, but I find it remarkable. And I think it's getting that disease control and being totally clear for a prolonged period, so we've got rid of subclinical disease, I think is going to be really important. So we're not just clearing the skin, but we're clearing under the skin as well.
But this is also the experience with the classical immunosuppressants in patients who have been on methotrexate for several years, a couple of years or 3 years, and if they achieve a good control, they can be withdrawn, and they will have a very long periods of eczema and of treatment. So I mean, dupilumab is excellent, but I think the response, the disease modifier is not simply linked to this or this other drug. I think it's eczema control with whatever drug you use. If it's working, we all know that very often immunosuppressants do not work, and we need better ones and more safer ones. But for those patients who get good control on methotrexate for a couple of years, you can withdraw and be completely or very, very reassured that they will have an eczema modifying regime in their life.
Thank you. And I think we all agree, we have a lot to learn. I've also had patients who do well for even a few years off, and then it comes back, and we don't understand that either. So much to learn. Let me bounce another question off of Dr. Gooderham, and I'm going to combine two that came in. If you could talk a little bit about two aspects on efficacy and safety. One was that they noted a tapinarof response. It seemed a little bit less with respect to placebo than what we see with the JAK inhibitors. What you think is going to be most efficacious, and then also the burning and stinging that we can see this with crisaborole. We've certainly had some of this with our topical calcineurin inhibitors. What is the future of the PDE4 inhibitors, and where do you see tapinarof and JAK inhibitors with this risk of the non-steroidals potentially burning and stinging?
I'll start with the first question about the difference with tapinarof. Just keeping in mind, we don't want to compare the trials because they had slightly different populations. The tapinarof phase 2 program was in a more severe patient population. They had an IgA of 3 or greater, and the JAK inhibitor studies were done mild to moderate. So we can't really compare the efficacy from those studies. Moving forward, hopefully at one point we'll have head-to-head studies, or we may have to rely on meta-analyses in the future. So I still think it's too early. Also with phase 2, smaller numbers, we'll have to wait for phase 3 results before we can start thinking about that. For the burning and stinging, I think we've all had patients who, if you don't talk about it when you write the prescription, they're likely to go home, use it once and never use it again. I still see that today, even though we've had these out for so many years. With the new agents, we're expecting to see these AEs in the population with the JAK inhibitors and with the PDE4 inhibitor, topical roflumilast. But surprisingly, we did not see the same rates. Now, I know with the other agents, the rates were lower in the clinical trials than we saw in the real world. So keep that in mind. But even the rates in these clinical trials were lower. So we'll have to get the phase 3 results for sure with a larger population, and then even some real world use to see how they will fit in. But I think it is very promising that we're not seeing a signal at this point.
Okay, thank you very much. This is for Professor Torello. Antonio, what do you think will be the comfort level with using some of these new systemic drugs under the age of 2?
We don't know because we need to use them before we know. But I'm a little bit in the beginning. We will all be concerned about when and how to use them. We will probably be using it only for those children who have not had a response to the classical topical drugs, or even short courses of oral corticosteroids. And even though most cases can be treated with the current therapies, there are some very severe patients who will need these new drugs, and I wouldn't be afraid of using them. So I think as long as they're safe, for me it's a very promising, good tool for trying to keep under control babies and infants who are not doing well with the current therapies. I think the new way you have just opened about treating very, very young infants is it's really amazing, and I think that in not in long future we will be treating these kids with these kind of therapies.
Yeah, but selectively.
Well, you can stop the world. In the beginning, we will be using it selectively, but later on, we will be decreasing the threshold of severity will be lower and lower and lower and lower through the years. And my prediction is that in 10 years, we will be treating with these new drugs children with moderate, even babies with moderate disease. There will be it will be difficult to skip this tendency to decrease the threshold of severity when we are starting therapy, as long as they are proved to be safe, as it looks like.
Yes, well, thank you, and I think we all agree.
Amy,
yes.
I completely agree with Antonio. We're already seeing quite remarkable responses down to 6 months with dupilumab in clinical trials, and in babies that have had potent topical steroids. And we all talk about not using systemic steroids. Well, we can't kid ourselves. We're not. That's a systemic effect. So with the potent steroids, so I think it's very, very encouraging. And I agree with Antonio. Gradually, our threshold will go down. And the other thing I find very encouraging is the tolerability. if we find children with needle phobia, with our psychiatrist, Sheva Shib, we're now going in proactively with cognitive behavioral therapy. So even that problem we can get rid of. So I think it's a fantastic time.
In any case, there will sure be problems. There will sure be a baby on any new drug who will develop a systemic or severe adverse effect. Yeah. This will happen. We cannot think that this won't happen, because this will happen, because we're blocking some immune response, and it will happen. And when it happens, let's see how it works, because we may also be developing dupilophobia or jackiphobia or whatever, because adverse effects will come up. There's no drug without adverse effects, and this should be known.
Yeah, and I think that I totally am in agreement with what's been said. I think that Mike's mention of the fact that when we're putting on potent topical steroids on a regular basis with that group of patients right now who have severe disease, even though they're topical, we do have concerns about doing that. So it's not like our non-systemic treatment is totally without potential risks, and we recognize that. We're getting short on time. I have one more question here, and I would like to hear a little bit from each of the panelists in terms of their experience before we close the session. And that is about some of the potential risks of dupilumab, a little bit more about the conjunctivitis in each one's experience. There's also a question about psoriasis-like lesions, and another question about inflammatory arthritis and what's been the experience in children with these particular issues. Now, I will say that in my own experience, and then I'll pass it along to whomever wants to join in next, I have seen conjunctivitis when doing the trials with children. I would say that I've seen less in the younger children. And since I've been able to use it off of studies, I will say also that I've been telling people prophylactically to put in bland drops or ointments into the eyes at least once or twice a day during the first few months, which is the period when there is a risk, particularly for the development of conjunctivitis, that seems to be increased. We don't even know exactly what this conjunctivitis results from, but what is interesting is that we've seen it increased with atopic dermatitis, but not with other allergic disorders for which dupilumab is used, suggesting that it is something about the eye and perhaps the eye barrier that's shared with atopic dermatitis that increases the risk. And there have been several studies now looking at, for example, reduction in the goblet cells that lubricate, et cetera. So far, since I've started using this prophylactically, I have yet to see anyone develop it, even though we know that there's the underlying risk in this population of having allergic conjunctivitis. I do have an ophthalmologist lined up for that in case something comes up. The psoriasis-like lesions, we have a series of 4 or 5 patients that we'll actually hope to publish soon, but I think it's extremely rare. I reached out to a large group of pediatric dermatologists in the United States, and none had seen it. There were very few, just the ones that I mentioned, that are out there, and I personally have yet to see inflammatory arthritis. So let me pass that to the other panelists in terms of these 3 side effects, any suggestions that you have, and what's been your experience.
I can go next. Conjunctivitis, I have seen cases more in adults than in children. I do find the prophylactic natural tears is helping. And if they do have any symptoms, I use like a topical antihistamine that's been also very helpful. I think I only have one more severe case that's really quite challenging, where we're using protopic as well as drops. And for the psoriasiform type lesions, I have not experienced that, but I did have one adult develop an arthritis on dupilumab, but that has, and I have a good population, and that hasn't been a major issue for me.
Thank you. Mike?
I'm very fortunate. One of my patients with severe atopic dermatitis is an anterior segment ophthalmologist with pre-existing dry eye syndrome. And he's given me a continuous masterclass on how to manage eyes. And I was just so impressed with this chap. So he said they had pre-existing dry eye syndrome, and that was from a particular type of laser corrective non-smile surgery. I won't go into the technical details. So he actually did his tear retention time and then calculated the number of times he had to have replacement tears. And I was really worried. I said, "You're going to get a bad problem with the pillow." I said, no, I've got it all sorted. I've got 20 times a day during the day, and then he had a different formulation at night. And he didn't have a problem. And then he had a bit of inflammation, and he used topical cyclosporin. And the take-home message is prophylaxis, as we all talked about. If there's a problem, get an ophthalmologist involved. Well, that was easy. And we always have an ophthalmologist. If they have an eye problem before we go on, we get a baseline assessment, because we all know it's complex. So dupilumab can cause dry eye syndrome, which we use replacement tears for, but an allergic conjunctivitis, which can occur with AD, can actually get better with dupilumab. So I think the combined approach of prophylaxis and involving an ophthalmologist and constantly is the best approach.
Any psoriatic-like disease or arthritis?
I have seen one, I'm going to write this out, absolutely fascinating child who got a granulomatous response. And we obviously checked for TB and everything. And we reduced the dose by 10%. It was actually in a trial. And when the dose went down by 10%, they disappeared completely.
Right.
And I thought that was fascinating. So just showing how critical dose can be, as with anything.
Thank you. And
Extremely rare.
Let's hear from Professor Torello, and we'll then close the program. Go ahead.
My practice is based on children. Virtually no conjunctivitis problems. Very easy to manage this, and no paradoxical or psoriasiform reactions in my population. And but this can happen, of course. I think my major challenge is to identify the good candidates for dupilumab because of heterogeneity of atopic dermatitis, especially in children. It is very heterogeneous, and I think it's a good selection of the clinical profile of the patient is the key for success.
Okay, thank you very much. If we could go to the next slide, I just want to thank all of you who attended this session, ask you to please complete the evaluation for our future session feedback. And not only is that listed here, but you should be able to find that in the chat room as well, so that you can fill out the survey and give us whatever feedback you can. I want to also mention that an on-demand webcast will be available on the IEC website shortly. So if you had friends who weren't able to get to this, or you want to share the word to learn more about atopic dermatitis, please do, and you'll find that again on the International Eczema Council website shortly. Thanks for coming, and enjoy the rest of your day.
Thanks, everyone.
Bye.
Thank you. Great session. Thank you very much.
Bye.